and I believe that some of you are here particularly to hear our featured speaker, Dr. Arjun Srinivasan. Arjun is the Associate Director for Healthcare-Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. He's board certified in infectious diseases and a fellow in the Society for Healthcare Epidemiology of America. A graduate of Vanderbilt University School of Medicine, Dr. Srinivasan completed an internal medicine residency and infectious disease fellowship at Johns Hopkins University Hospital. Before coming to the CDC, while he was practicing as an assistant professor in the Infectious Disease Division at Johns Hopkins School of Medicine, he was the founding director of the Johns Hopkins Antibiotic Management Program and the associate hospital epidemiologist. His primary responsibilities at the CDC include oversight and coordination of efforts to eliminate HAIs. His research and investigative areas of concentration include outbreak investigation, infection control, multi-drug resistant gram-negative pathogens, and antimicrobial use. From 2006 to 2010, he led the CDC's Healthcare Outbreak Investigations Team. In 2008, he assumed the medical directorship of the new CDC campaign called Get Smart for Healthcare, which is designed to improve the use of antimicrobials in inpatient healthcare facilities. Dr. Srinivasan has published more than 70 articles in peer-reviewed journals on his research in healthcare epidemiology, infection control, and antimicrobial use and resistance. Please help me welcome our featured speaker, Dr. Arjun Srinivasan, who will deliver our keynote address, Antimicrobial Stewardship, Where We Are, A Vision for the Future, and Charting a Path to Get There.
Thank you so much, Shirley. What a pleasure to be here with all of you. This is a fantastic turnout. What a wonderful conference that you guys have all put together. I do want to say I want to thank the organizers for helping me schedule this so I could get back for Little League tonight. But that means I have to leave after the break. So I will be here during the break and would love to talk to any of you who are interested in speaking with me, but I'll be leaving at around 10:30. But my email is up there, so I do hope to hear from you long after this is over via email. I also want to acknowledge that I am acutely aware that I'm the very definition of the guy who is the expert because he got on a plane to come here and tell you all the things that you already know. All of you could be up here giving this talk. You've got a lot of local expertise. I am honored and humbled to be here to share some of what's going on at CDC with antibiotic stewardship. I mean, this is a really exciting time for antibiotic stewardship, and I think the turnout here really reflects that. I don't have any financial disclosures, but I will mention that I'm going to talk pretty much exclusively today on antibiotic use in hospital settings. And I've already had some discussions with many of you here today, and I think we all acknowledge that there are really important needs to improve antibiotics in other types of healthcare settings as well, ambulatory settings, doctors' offices, long-term care facilities. We've got Robin Jump here as one of the national experts in that area. So there is a lot of work that's happening in those areas, that's work that's happening in agricultural settings. I don't have time to cover all of that, but rest assured there are activities going on in those other areas as well. You know, all of you here know all of this. We have to improve the way we use antibiotics. Most importantly, because antibiotics are a shared resource. They're the only medicine that we use where the way that I prescribe them can impact how effective they are in your patients, whether I see patients in your hospital or in your state or even in your country. They are the only drugs that fall into that category. They're the only drugs that, by design, will lose their effectiveness over time. They're the only drugs that the more we use them, the less effective they become. So that means that we are truly in this together. So all of us have a responsibility. Society writ large has a responsibility to improve the way that we use antibiotics. We know that a lot of antibiotic use is either completely unnecessary, it's given to patients who don't need them at all, or even when it's given the wrong way. We're giving the wrong drug, we're giving it for too long, we're giving the wrong dose. We know that we're running out of antibiotics. The pace of antibiotic development has slowed dramatically. I think that's getting a little bit better, but not good enough that we are in a situation where we don't have to worry about it, because there's going to be 15 new antibiotics next year, so there's nothing to be concerned about. I think we are now in a new reality where even if antibiotic development picks up, it'll be a trickle. We might see a few antibiotics, 1 or 2 a year, but we're not going to be able to just drug discover our way out of this problem. And we know that improving antibiotic use has a number of important benefits, not just for individual patients, but also for healthcare systems and for society at large as well. Where do we want to be? I think the ultimate goal on the inpatient side is that every hospitalized patient in every hospital in the United States gets optimized antibiotic treatment. We at CDC think the way to get there is for every hospital in America to have a good antibiotic stewardship program to help us get to that goal, and that every stewardship program uses proven best practices to improve the prescribing of antibiotics in that setting. Well, if that's where we want to be, how are we going to get to that goal? And I think we can take some lessons that we've learned from our experience in healthcare-associated infections to help us figure out how we need to get where we want to be. We have, in this country, done a pretty good job of preventing central line-associated bloodstream infections over the past decade or so. We've seen these infections drop by about 50% across the board nationally, which is a pretty remarkable success. I think if you had asked someone a decade ago, how much could you lower central line associated bloodstream infection rates? I think people would have said, maybe 5%, maybe 10%. If you said 50%, people would have said, you're crazy. 50%, that's ridiculous. Yet we've done it. Not just in 1 or 2 hospitals, we've done it as a country. How did we do it? Well, we had really well-defined programs and interventions with good education and good implementation. We knew exactly what we needed to do, and we went out and we did it. We had a strong national measurement system. We could measure CLABC rates, and so we knew where we were. We knew how far we had to go to get where we needed to be. We had a national emphasis on solving the problem. We set big national goals. We said, look, as a country, we are going to reduce these infections. And that helped implement new policies, action to drive where we needed to go. And then we invested in research. We invested in understanding how we needed to prevent these infections. And so I think that's exactly what we need to do for antibiotic stewardship. We have to replicate all of those things that worked in infection control, worked for preventing central line associated bloodstream infections, and apply them to antibiotic stewardship. I think we know a lot about what worked. We know a lot about what didn't. So now our task is to replicate what worked and fix what didn't to apply it to antibiotic stewardship. A first step, of course, is to begin to define what exactly is antibiotic stewardship. What is an antibiotic stewardship program? And I think this is something that kind of sounds obvious when you start thinking about implementing these programs. But if you look back and look at previous ways that these programs have been defined, there were some really good guidelines from groups like the Society for Healthcare Epidemiology of America, the Infectious Diseases Society of America. But when we went out and started talking to people about those guidelines, they said, they're fantastic, and they're really, really good if you're a large academic medical center where you've got ID docs and ID pharmacists and microbiologists, but we're a 25-bed critical access hospital. We don't have access to an ID doc. There are no ID docs who come here. We don't have an ID pharmacist. We don't have a micro lab here. So we can't follow those guidelines. We need something different. We need guidelines that we can follow. And so we needed to define an antibiotic stewardship program that would be applicable in every hospital. And so what we did to try and do that at CDC was develop what we have come to call the core elements of hospital antibiotic stewardship programs. And we developed these core elements based on experience that was published and presented on successful stewardship programs from a variety of different hospitals. So yes, some large academic medical centers, but also very small hospitals. And what we said is, look, let's try to define what you've done. What are the things that you've done that have made your program successful? Let's not define the who, because if we tell people it has to be an ID doc or it has to be an ID pharmacist, we will instantly lose the facilities that don't have access to those types of people. So let's try to figure out what you did, and then let facilities figure out who would be best to do it in their setting. These are the ones that we came up with. There are 7 of these core elements, and let me just walk through these very briefly. And I think what you'll find is that these core elements, I'm talking about them for antibiotic stewardship, but you could probably apply any sort of quality improvement effort into this framework. These are elements that I think are very, very common across quality improvement. There's got to be a commitment from the leadership of the facility to support what you're trying to do. The leadership has got to really be engaged. We know that any quality improvement effort that's not backed by the C-suite of the hospital is probably not going to be successful. It's the leadership who can ensure that the people who are assigned the tasks of stewardship have the time and the resources they need in order to get that stuff done. We know that money helps everything, and so financial support helps stewardship programs, but we have talked to hospitals who have said, you know what, the money piece was not as important for me as having my leadership really on board and visibly supportive of what I was trying to do. We think there needs to be a single person who is designated as the leader of the stewardship program. We know in many instances people have said, look, we like to have a physician as the leader of our program, at least on paper, because prescribing is a medical staff function. And when it's time to go and have that difficult discussion with a physician about their misuse of antibiotics, it's helpful if that comes peer-to-peer, it comes from another prescriber. But we also know that pharmacy leadership is absolutely imperative for antibiotic stewardship programs. I would defy you to find a successful antibiotic stewardship program that doesn't have a strong pharmacy leader. In most instances, I would say that these programs are co-led oftentimes by physicians and pharmacists. What we do know is that leadership by committee doesn't work. If you say that the leader of our stewardship program is the Pharmacy and Therapeutics Committee, that leadership gets diffused, and so there's nobody who's really on point and who's driving the program forward. We have to track antibiotic use, and this has historically been a significant challenge for us. We're making headway in this area. We have a long way to go, but we know that we have to find good ways to track antibiotic use. We say in epidemiology, you can't improve that which you cannot measure. So we've got to measure antibiotic use to find where those opportunities for improvement are and to know whether or not the things that we are doing are leading to meaningful improvements in antibiotic use. I'll say a little bit more about the antibiotic use option of the National Healthcare Safety Network. That is the system that we have developed and put forward to try and allow hospitals to track antibiotic use to inform their stewardship efforts. Reporting and education are, fundamental for all that we do in quality improvement. They fall into that category of things that we say are necessary but not sufficient. We have to report, we have to educate. We know that these things on their own aren't going to lead to the changes that we need, but people need to know. They need to know how they can improve their antibiotic use. They need to know about the drug resistance that's present in your hospital, in your community. They need to know about Clostridium difficile, the types of things that we're trying to address by improving antibiotic use. And finally, we have to implement specific improvement interventions. This is really where the rubber meets the road. All of the other things are building the infrastructure so that we have it in place in order to do these interventions to improve antibiotic use. The literature, I think, is replete with examples of types of interventions. They're for specific infection types, pneumonia, urinary tract infections, skin and soft tissue infections. There are interventions for specific drugs, classes of drugs, interventions for Clostridium difficile. The key, I think, is to figure out which intervention makes the most sense in your particular setting. Talk with your providers. randomly look at a few charts. Look to see where there are opportunities to improve in your hospital, and then build your intervention around that. It's always most effective when you design your intervention to address a problem that's locally relevant and locally meaningful. Well, those are the core elements of stewardship programs, and what we're trying to do at CDC is get a sense of how well we are doing as a country with respect to the implementation of these core elements in different hospitals. To begin doing that, last year in 2015, we added questions to our annual facility survey of the National Healthcare Safety Network. And the 2015 survey, for those of you who are familiar with NHSN, know that it covers what was going on in your hospital the previous year. So every year, we survey all the hospitals that are participating in NHSN and ask them to answer a bunch of questions about what they were doing the year before. So the data that I have for this covers the activities that hospitals had going on in 2014. This was the largest ever survey of stewardship programs nationally. There are over 4,000 hospitals that now participate in NHSN, and all of them have to answer these questions in order to stay enrolled in NHSN. So it's a voluntary mandatory survey. We designed the questions based on the CDC core elements to get a sense of how people were doing with implementing those. And you know, the number that we came up nationally was 39%. You know, I tell people, you know, you can look at that number as either a glass half full or a glass half full way. You can say that, hey, you know, 39% of hospitals in the United States have implemented all of the core elements. Or you can say 39% of hospitals in America have implemented all the core elements. All depends on how you look at it. I like to joke with people that if you do antibiotic stewardship and infection control, you are by definition an optimistic person, because if you weren't, you would never be able to get out of bed in the morning. The factors that we know are associated in this survey with being able to meet all the core elements are, I think, ones that would come as no surprise to any of us. If you're a larger hospital, you're more likely to meet them. If you're a teaching hospital, you're more likely to have all 7. Again, I think there's a lot of overlap between those two. Teaching hospitals tend to be larger hospitals. What was interesting to us, and I think it's real because I've had them rerun this particular analysis so many times that all the analysts are sick of me asking them about this, but when we looked at leadership support, having leadership support was the most predictive element for having the other 6. That part came as absolutely no surprise to me. What floored me was that the places who had written support, that was even more strongly predictive than having financial support. And I was really, you know, was just didn't make sense to me. So I began talking with lots of people to think, look, this is what we're seeing in the data. And surprisingly, a lot of people have said, yeah, that makes sense to me. Because, you know, just them writing a check is not as meaningful as our CMO, our CEO being really, really engaged with what we're doing. However, we know that salary support makes a huge difference as well. So I don't want to convey that we don't need salary support, but it is important, I think, to have both. Everybody has to have a map. So here's our map. This is what the percent of stewardship programs by state. And all of you can find Missouri very quickly and see that you're at 29% right now. I think that you will be very quickly moving past a lot of other states because of all the activity here. So there's definitely room for more improvement here, and all of you are here to make that happen. You know, a lot of hospitals have told us that they said, you know, the core elements, they're great, they make sense, but they're a little bit too vague. They're high level. We need more help with implementation. We would love to know specifically, when you say leadership commitment, what does that look like? What are examples? And so to try and help do that, the CDC partnered with the National Quality Partnership, which is part of the National Quality Forum. And the National Quality Forum is this quasi-governmental agency. They get funded by the government to do improvements, set improvement standards for the country. They've got about 400 different organizations that are members of this group. And they've created this National Quality Partnership, which is to engage these members in actually trying to work on quality improvement efforts. And so what we did with them was develop what we call an antibiotic stewardship playbook. And so the idea for it was, let's get people together who have implemented core elements who've implemented stewardship programs, and let's come up with examples. Let's show people what does implementation look like. Let's give them specific examples of implementation, talk about barriers for implementing the core elements, talk about how people have overcome those barriers. And so we assembled a group of experts who were doing antibiotic stewardship, representing a host of different types of healthcare facilities, ranging from a critical access hospital in Cortez, Colorado, to 1,000-bed tertiary academic medical centers, along with a number of different, 20 different professional organizations. And this playbook was released in May of 2015. It's up on the web. It's been really wildly successful. It's definitely exceeded all of our expectations. Since it was posted in May, it's been downloaded 12,000 times, and so clearly, there's a need for it. People seem to like it. And just to give you an example of what it looks like, this is just one row from the playbook, but this is under the leadership commitment bucket. So the example that someone put forward was, what we did is we had our board of our hospital issue a formal statement on the importance of antibiotic stewardship and the hospital's commitment to stewardship. Somebody raised that, a barrier that they had in their hospital was that, it was hard to get leaders to stay focused on this. It was hard to get them to really support stewardship. And what they did to try to overcome that was they shared with leaders reports, national reports from the White House on antibiotic stewardship and how important this was. And they directed them to things like the Joint Commission requirement. Here, of course, you've got a state mandate to show them that, look, it's not just a good idea, it's something that we really have to be doing. And then there is a tool here, there's a slide set on making the business case for antibiotic stewardship. So it walks you through how you might go and make a case for support to your C-suite. So that's just one example of what's in the playbook. Let me turn and spend a little bit of time talking about measuring antibiotic use in hospitals, because this is an area where we have historically struggled. It can be hard to measure antibiotic use, and so we've been trying to overcome this barrier. Like I said, I think we're making progress. We still have a ways to go. And for measuring hospital antibiotic use at CDC, we're trying to approach this on what we think are three different but equally important fronts. The first is that we would like to have some national estimates of aggregate antibiotic use. We want to be able to take that national picture and show people what's going on in the country. There are a couple of different ways that we're trying to do that. One is through an annual survey that we do through our Emerging Infections program that does a survey in 10 different states that cover a fair bit of the country and that can be extrapolated a little bit nationally. There is also some data from proprietary sources that you can buy, and we've bought some of this data that are allowing us to try and construct some national estimates of hospital antibiotic use. We think, though, that the most important piece of this is the facility-specific information. It's really knowing what's going on at the front lines in these different hospitals, and that's where we have the antibiotic use option of the National Healthcare Safety Network. And finally, the goal of antibiotic stewardship is to improve the optimal or appropriate use of antibiotics, which means we also need to invest some serious energy on trying to assess appropriate use and figure out ways that we can measure appropriate antibiotic use. And I'll say a few words about how we're trying to begin doing that in the Emerging Infections program. The antibiotic use option of NHSN is the system that we have that allows us to capture electronic data on antibiotics that are actually administered to patients. It combines that with the admission, discharge, transfer data from your hospital in order to produce rates of antibiotic use. So it gives you the rates of antibiotic use for different drugs with days of therapy per 1,000 patient days. And the reason that we went this route, that we have done days of therapy, is because Dr. Newland was one of our expert advisors, and he constantly was telling us you can't leave kids to the side. We have to have something that's relevant in pediatrics, and we agree 100%. So this measure is something that's relevant in peds, relevant in adult settings as well. The functionality of NHSN, we designed it in collaboration with a number of different experts because we knew that it had to be multifunctional. People told us that we need data at our facility level. We need need to know what's going on in our hospital so that we can track our interventions and look for opportunities to improve. But we would also like to be able to aggregate that data. We'd like to be able to look at it. Maybe if you're Eddie, you want to look at antibiotic use in the state or in a region, and we want to be able to look at this nationally. And finally, what the experts told us is the highest priority would be to construct benchmarks for antibiotic use. They said, look, in quality improvement, benchmarking is what drives improvement. It's my ability to go and say, look, here is where we are, and here is where everybody else is. We need to improve. I think it speaks to how insanely competitive healthcare is that the best way to motivate behavior is to go in and show people that you're doing worse than the hospital that's down the street from you. Enrolling in the antibiotic use option, what do you need? What are the requirements to enroll? So what you need to have access to is electronic data on antibiotic administration. So that would have to come either from a barcode system or an electronic medication administration record. And I know that not every hospital is here. We know that the field is moving in this direction. I think the last data I saw said that about somewhere between 60 and 80% of hospitals in the country now have either EMR or barcode administration data. It's not quite yet 100%. So we know that this was built a little bit for the future. You cannot use doses that are dispensed from the pharmacy. It actually has to be what's administered to patients. And then you have to be able to link that to your admission, discharge, and transfer system. The easiest way to submit data into the antibiotic use option is through a vendor system. This has been slow going. I would readily acknowledge that. There are only about 100 or so hospitals that are currently submitting data. But the good news is that more and more vendors are beginning to add this functionality as they begin to really see the writing on the wall. With stewardship mandates, with your law here in Missouri, they're beginning to see that this is something that they need to begin building into their programs. And so several of these systems have it, and a lot more we've heard are adding it. There's a website here which really has all the basic information about getting started, and there's an email that you can send if you have questions about it. If you need help, we're happy to help walk you through this process. When we think about benchmarking antibiotic use, though, this is something that is really, really challenging. It's much more difficult than benchmarking infection control. And it's really different from benchmarking any of the other quality measures. If you go into the National Quality Forum and you look at their quality measures, essentially every one of them has a goal that's either 100% or 0, right? We know that nobody should have an infection in a hospital. We know that everybody should receive counseling for smoking cessation when they're admitted to the hospital. Antibiotic use is fundamentally different from all of those. We know we use too much antibiotics, but how much too much we don't exactly know, and it's different from different places. We know that being an outlier, having really high antibiotic use, might mean you have a problem, or it might mean that you have a big bone marrow transplant unit, right? So we can't necessarily say that just because you're high, you're doing a bad job. And anytime you start doing benchmarks, you really have to be aware of any unintended consequences that you might be created. With all of that in mind, we have developed an antibiotic use benchmark. It's called the Standardized Antibiotic Administration Ratio. This was our first foray into developing an antibiotic use benchmark. It's very similar in principle to the Standardized Infection Ratio, for those of you who are familiar with that. What the Standardized Antibiotic Administration Ratio does is it expresses your antibiotic use as observed use compared to expected use. So this is exactly what we do for infections, where we compare the observed number of infections in your hospital to the expected number of infections, and we give you a ratio. So that means that if you have a ratio of more than 1, you are using more antibiotics than would be expected based on comparison hospitals. If you're less than 1, you're using fewer antibiotics than your comparator hospitals. And we really worked with a lot of different partners to try to make this measure really actionable. We wanted a measure that was relevant for stewardship, not a kind of bureaucratic measure that would sit on the shelf and not be used. And so what the experts told us is they said, look, don't come to me with an aggregate measure of antibiotic use at my hospital. That would not help me at all. Knowing that as a hospital, I use 10% more antibiotics than a hospital down the street, I can't do anything with that information because it doesn't guide me to where I might need to go improve use. So what they said is, I want to see ratios, I want to see comparisons broken down in a host of different ways. I want to be able to see it by different populations. So adult and pediatrics need to be separate. ICUs and wards need to be separate. And they also said, when I think about improvement, I'm going to go after specific agents or specific categories of agents. So I want you to show me my ratios. I want you to compare based on a number of different categories. And these were the categories that were suggested and that we settled on. So we can calculate ratios for the antibiotics that are primarily used to treat healthcare-associated pathogens. So these are carbapenems or piptazos, things like that. We can calculate a different ratio for agents that are primarily used to treat community-onset infections, like fluoroquinolones, third-generation cephalosporins. There's a bucket, a ratio for agents that are active against MRSA. There's a bucket for agents that are frequently used for surgical prophylaxis. People said it would help us to know. We can maybe try to improve our use of surgical prophylaxis agents if we had that ratio. And finally, there is an all agents category. So if you do want to get that overall snapshot, which some people did say that would be helpful too, we have that category as well. A few important things to understand about the standardized antibiotic administration ratio. As all of you probably know, the data that we have in NHSN is high-level data. So we can only do risk adjustment based on facility-level characteristics. We can risk adjust based on whether or not you have ICUs and how many ICU beds you have. We can risk adjust based on whether you're a small hospital or a large hospital, teaching or non-teaching. We can't risk adjust for the number of oncology patients you have in your hospital. We can't risk adjust for how many infectious disease ICD-10 discharges you have in a year. So we can risk adjust on some things, but not everything. And what we've done in these calculations is we have used these facility and location characteristics that we have access to do risk adjustment models for all of the different SAAR categories. We did submit the standardized antibiotic administration ratio to the National Quality Forum for review and endorsement. We wanted to have an external body review the measure, give us feedback on the measure, and they did that. And earlier this year, in January 2016, they formally endorsed the standardized antibiotic administration ratio measure. That was an important step for us because it does provide some degree of external validation for the measure. We applied for the measure only for public health surveillance and quality improvement. We did not apply to have the measure be part of payment determinations in hospitals. We don't think the measure is there yet. There is the possibility that someday it might be, but right now we know we have a lot of work that we need to do to understand the measure before we ever get to something like that. The SAAR calculation is now available in the antibiotic use option, so if you are enrolled in that option, you can click a button and get these benchmarks for your hospital. Important to note that the ratio, as I mentioned earlier, it doesn't necessarily tell you that use is bad or good. It only tells you that it's high or low. Your high use might be perfectly justified. You might go to a unit and find that they're doing a great job with antibiotics. It's just they have a high-risk patient population. Likewise, you might go to a unit that it has very, very low antibiotic use and find that they're underusing. They're not treating infections the way that you might like them to do. So what the SAAR measure does is it directs you. It allows you to kind of focus your resources on areas of your hospital that appear to be outliers. Why they're outliers is then the meat of what has to be done. What you have to do is figure out why are we higher or lower than the norm. Now, I mentioned that we did not apply for this measure as a payment measure, but CMS is very interested in antibiotic stewardship, and they are looking for stewardship measures. And so they have solicited public comment on what would need to happen. What are the thoughts on potentially making the SAAR part of the inpatient quality reporting program moving down the road. So that's something I think that's important to note. I mentioned that the ultimate goal for us is to improve appropriate antibiotic use, and that means we need to find a way to measure appropriate antibiotic use. So that's something that we have not been able to do historically, and when we have, it's been very, very labor intensive. And so we've been exploring a number of different ways to try and do that in a way that's not quite so hard. One of the things we've done is we've collaborated with a bunch of external partners to create some assessment tools, antibiotic appropriateness assessment assessment tools that are available as Word documents on our website. So these are intended to be quality improvement tools that could help you go and look at antibiotic use to see if there are opportunities for improvement. But we recognize that as quality improvement tools, they need to be modifiable. So these are tools that experts develop, but you can take them, they're Word documents, you can modify them in any way that works best for you, and then apply them in your hospital. There's no rules about it's got to be this many charts and this many units. No, these are simply quality improvement tools. Pick any number of charts you want to do, apply the tool, and it gives you some sense of whether or not there might be opportunities for improvement. What we are doing nationally, though, is we've kind of modified these forms and embedded them into the national survey that we're doing on antibiotic use, prevalence, and healthcare-associated infections. So this is a survey that was done for the first time in 2011. It's being repeated right now. And this survey will include, for the first time, a kind of national assessment within these 10 states, about 200 participating hospitals, and we're going to try to assess the appropriate use of two different agents, vancomycin and fluoroquinolones, and two infectious conditions, community-acquired pneumonia and urinary tract infections. And so we're hoping to get, really for the first time, a national snapshot of how well we are doing with antibiotic use for those two agents and those two conditions. I'll turn a little bit and talk about national goals and policies and why are these types of national goals and policies important. Well, we've known for a very long time that there are proven benefits to antibiotic stewardship programs. There have been tons of papers published about the different benefits that antibiotic stewardship programs have. And yet, despite that, we know that not every facility has a really well-supported antibiotic stewardship program. And if you go back and you look at the history of infection control, that's not too different from where we were in the past with infection control, where there were lots of benefits. We knew that infection control worked, and yet infection control was not a top priority for most hospitals. I don't think that's the case for infection control now. I think infection control has moved way up on the priority list. I can tell you that there were CEOs who previously didn't know that they had an infection control department, and now they can tell me their CLABSI rates going back the last 6 quarters. So it's the national policies have definitely changed the perspective on the importance of infection control programs, and I think they can do the same for stewardship. There is now a huge national emphasis on antibiotic stewardship as an important part of efforts to address the growing problem of antibiotic resistance in America. This is something that I think has been widely recognized nationally, and it rose to the point of being such an issue that the White House said, look, there really needs to be a coordinated response across the country to try and address this problem of antibiotic resistance because people are dying of infections that we can't treat with antibiotics. So we do now have a national action plan for addressing antibiotic resistance, and antibiotic stewardship is really one of the core pillars of that national action plan. And so that has led, I think, to a lot of different activities. A couple of years, last year, there was a forum at the White House on antibiotic stewardship. This, I think, was a bellwether moment for antibiotic stewardship. So this was a forum that was called together by the White House to talk just about antibiotic stewardship, not about antibiotic resistance, not broadly about healthcare-associated infections. This was just about antibiotic stewardship. Jason was there, and I'm shamelessly showing you this slide just so I can show you that there's a slide that has the White House logo sitting on top of antibiotic stewardship. There have been a lot of really important developments that have happened really just in the last couple of years for antibiotic stewardship. I'm going to talk about just a very small number of those. But one of the biggest ones is resource development. In 2016, Congress passed a budget that included significant support for a request that the president had made to increase funding to help address antibiotic resistance, with stewardship being a key component of activities that needed to be funding. And I can just say that something has reached an unbelievable level of importance when the president and Congress can both agree to spend money on it. The resources that will come are going to really try to address a number of key gaps in measurement and implementation of stewardship, and are really going to help bolster the capacity of state and local health departments to support stewardship activities. One of the things that we've heard is people really want access to training like this, to local expertise. That costs money. And so what we are going to do is try to provide states with some resources so that this type of program can be done on an annual basis here. It can be replicated in other areas. And we hope it will provide the state health departments with the ability to bring on some of that expertise to support hospitals in their efforts to improve antibiotic use. There have been a number of incentives that are moving forward for antibiotic stewardship. In 2016, Anthem Healthcare, so one of the largest insurance companies in America, added compliance implementation of the CDC core elements to something that they call the Quality Insights Hospital Incentive Program. And what this is a program that about 1,000 hospitals are eligible for, and you can get increased payments by earning points in different areas. So they have a number of different criteria that you can meet to earn points towards getting increased payment. And so now the CDC core elements are one of those buckets. And so if you have implemented all 7 of the core elements, you get bonus points towards these added payments. The Leapfrog group is adding questions on the CDC core elements into their annual survey. That doesn't come with money, so why is that an incentive? Well, those of you who are familiar with Leapfrog know that this is a very, very influential survey for a lot of hospital administrators. They want to do well on these surveys, and so now in order to do well, they will have to show that they are implementing the CDC core elements. CMS, as an incentive, has proposed that reporting antibiotic use into NHSN could be part of getting your meaningful use stage 3 payment, so that should provide some financial support for information technology resources to come into this area as well. I'll turn now and talk about what I think are some of the biggest developments for antibiotic stewardship, and those are accreditation and regulatory requirements. We were talking before, we know that what really transforms healthcare is when things move over and go from being voluntary to being required. That is where we see the huge influx of resources come. It's when we see people really begin to move. And so late in 2015, the Joint Commission, I think, recognizing the importance of antibiotic stewardship and the need for some sort of a standard to get people to a common playing field on stewardship, proposed an accreditation standard for antibiotic stewardship for all their accredited facilities. That standard has 8 performance elements. It's been finalized. It was released this summer, and compliance is required starting in January of 2017. So this means that starting in 2017, your Joint Commission survey will include questions on your implementation of antibiotic stewardship. So obviously a major development for antibiotic stewardship. Let me walk through these accreditation standards. Many of you may have seen these, so I apologize if you're familiar with them, but I think this is important enough that it merits very quickly walking through what these elements are, because these are the things that you are going to get surveyed on if you're a Joint Commission accredited hospital. How many Joint Commission accredited hospitals here? So a pretty fair number. I think they have about 80% of the market, so they do accredit a lot of facilities. Leaders have to establish stewardship as an organizational priority, speaks to the leadership commitment. There has to be education for the staff in your hospital about antibiotic use. There has to be education for patients and families about antibiotic use. You have to have a multidisciplinary team to support your antibiotic stewardship efforts, and you need to bring into that team all of these different areas if you have them in your hospital. So pharmacy, infectious diseases, infection prevention. You have to incorporate the CDC core elements, so they embedded the core elements into the performance standards. Although I think if you've got the core elements, you also are meeting all of the other ones as well. You used approved protocols and guidelines in your program. The 7th is that you look at data on antibiotic use and antibiotic stewardship, and that you take action on the areas that you identified. You move to improve antibiotic use based on the opportunities for improvement that you've identified. The other major development, of course, that was announced really just about a month ago now is a proposal to have antibiotic stewardship programs become a requirement for all U.S. hospitals that receive federal funding. So to make them a condition of participation in the Medicare payment program. So this is obviously a huge driver because the Joint Commission is a major driver. It hits a lot of hospitals, but this one applies to everybody. Everybody who gets federal funds has to implement the conditions of participation. So this is a proposed rule. It was announced last month. It's open for public comment until mid-August, and then CMS will work to finalize the rule. And let me just walk you through what CMS is proposing. It fits into the infection control section, and what they have done is said in the past, there was an infection control condition of participation, and now that's going to read the infection control and antibiotic stewardship condition. So you would need to have an active hospital-wide program for antibiotic stewardship to optimize antibiotic use in addition to your infection control program. That you would have a leader of that program, an individual who's qualified to lead your program. And what's important to note is that they've clearly differentiated. This cannot be something that's just foisted onto the activities of an already overworked infection preventionist. The infection prevention program needs a leader. The antibiotic stewardship program needs a leader. Now, in some hospitals, that may be the same person, but it doesn't have to be. So this isn't something where you can just say, oh, we've got an IP. We're going to make her or him be the leader of the stewardship program now. There are different qualifications that are necessary to run each of these programs. You have to have a stewardship program that is active throughout your hospital and that works to coordinate all of the stewardship activities in collaboration with your quality improvement program and with infection prevention. And that you are documenting that you're using evidence-based guidelines for stewardship in your hospital. You have to work to demonstrate improvements. You can look at a number of different things. The thing that they proposed are things like C. diff and antibiotic resistance. We all know those are complicated. They're multifactorial. They are not the only things you can measure. It says these are examples of things that you could measure and monitor. And there's also an important mention that the stewardship program needs to reflect the scope and complexity of the hospital services provided. This is an attempt to build in that flexibility, but to clearly say, you know, if you have got a 1,000-bed hospital with a bone marrow transplant program and an organ transplant service, we are going to hold you to a different standard than we are if you're a small community or a critical access hospital. The leader of the program has responsibilities. They have to implement that program effectively. And the leadership of the hospital also has responsibilities. There is specific mention that the hospital leadership, the board, the governing body, has specific responsibilities to support the antibiotic stewardship program, just like they support the infection control program. There is a requirement for some sort of training and education to happen on an annual basis. And so I think you'll see that a lot of the requirements in the CMS condition are similar to the Joint Commission requirements and are similar to the CDC core elements. So I really do think there is quite a bit of harmony between all of those different things. So if you are implementing the CDC core elements, you're in compliance with the accreditation standards, you'll be in compliance with the condition, and the same holds true for any of the others. If you're implementing the Joint Commission standard, you're meeting the core elements, you'll meet the CMS requirements. So I think that's good, those requirements are similar. Let me turn now and talk now about Missouri Senate Bill 579. This is the most proactive antibiotic stewardship legislation in America right now. A lot of people, when I told them I was coming to Missouri to give a talk, they're like, "Oh, well, why are you going to Missouri to give a talk?" And I said, because they have the most, they have the best antibiotic stewardship legislation, the most active antibiotic stewardship legislation in the United States. And they said, "You mean Missouri? Like Missouri has the best bill?" You do. It's I think the most comprehensive legislation on antibiotic stewardship in the United States. It states that by August of 2017, every hospital in Missouri has to have an antibiotic stewardship program. Lots of descriptions here. I put the slides in here. I'm not going to read all of the text. They're there for you in the slides, but I wanted to give you a sense of what's in the bill. I know many of you in this room are very familiar with the legislation. Some of you in this room helped write the legislation. It does say that hospitals will report information into the AU option once meaningful use stage 3 comes into fruition. So there's an incentive there as well. There are requirements for reporting. It's important to note, I think the bill is well written in that the facilities will share information on antibiotic use with public health authorities, but this information is not going to be reported to the public. I think we all recognize that right now antibiotic use is not something that we can readily explain to the public. We don't know what this information means. If you use 10% more, maybe it's perfectly justified. And so we don't think that this is information that is ready to be publicly reported, but we do think that sharing it with public health authorities, trying to get a sense of what's going on in the state could be very, very important. Well, I think that this is an unprecedented time for antibiotic stewardship. We've been at this for a very, very long time. There are people who've been doing this for even longer than I have, but we've been at antibiotic stewardship for decades now. I think we are finally on the cusp of really making transformational change. I tell people that it's always been a good idea, and now it's just a good idea that happens to be required. We need to do stewardship, but we need to do it right. We have to figure out the right ways to do this, and that's where all of you come in. We're early in this process. We have a lot to learn, and we are eager to learn from you. I am eager to hear from you. What's working, what's not working, what of this looks good, what do you think is going to be hard to implement, and most importantly, let me know what we can do. What can we at CDC, what can we do at the national level to really help support your efforts to implement antibiotic stewardship? I'm here today. I'm happy to discuss some of that, but I do have my email on the slides. If you do have thoughts, I'm really genuine, and I really want to hear from folks. It's incredibly helpful to hear from people who are on the front lines, who are implementing stewardship programs. It really does help inform and direct our efforts. So with that, I'm going to close, and I think we have about 10 or 15 minutes for questions. So thank you very much, and I'm happy to take any questions if you have them. Thanks a lot. And there are microphones, I think, here and here. So if you do have a question, please step up and come to the microphone. And I'll stand here awkwardly until someone stands up and asks a question. Hey, how are you? Nice seeing you. Yeah, you too. So I have a question for those of us who do stewardship and who are trying to... Oh, can you... Yeah, same here.
So, for those of us who are doing stewardship and who are trying to get the AUR module implemented, there is a lot of concern that the SAAR, like you talked about, isn't fully capable of really risk adjusting for the patient populations in certain hospitals. You talked about how it really is sort of facility level data that the SAAR looks at. Mm-hmm. Is there any reason why sort of lower down patient level or clinical factors can't be sort of added into that in future versions of the SAAR? Because, for like line infections, we use line days as the denominator because otherwise it makes no sense to even consider it. So is there an intrinsic issue with adding that stuff to the SAAR?
There isn't. It's all an issue of labor to collect. So the trick is to balance the labor required to collect information versus what we can do with the information. So what we are doing right now is working with a couple of different health systems who are reporting data into the AU option, but who have really robust electronic health records where they have all of the patient level data. And so what we're doing we're working collaboratively with them, and so what they are doing is they're taking the standardized antibiotic administration ratio, and they're saying, okay, let's start adding in more patient-level characteristics, and let's see what happens. How much better does the risk adjustment become if we add ICD-10s? Now, what happens if we add ICD-10s plus oncology diagnoses? Now what happens if we add white blood cell counts, culture results. And so they have access to all of this information. So what we're looking for is, what's kind of the most parsimonious model? What can we collect that's going to really help us do a better risk adjustment that is not so labor intensive. And then the vision is absolutely we're doing the project to then figure out, okay, what we think we need is what we've got plus ICD-10s. And that gets us, 95% of the way there with just one more data element that we could extract electronically. So yeah, we're absolutely working on that. I think it is really important to understand.
Great, thanks.
Yeah.
Thanks, Arjun. That was a fabulous presentation, as usual. There's been obviously a lot of focus on the antibiotic use module, and obviously that's that initial piece we have to get done. Could you give us any updates on the resistance piece of that and how that's going to obviously play in the future?
Yeah, absolutely. Thank you, Jason. So, the module is called the Antibiotic Use and Resistance module. So there is an option to also directly report laboratory information on resistance, and that part of the module is a little bit further behind. It's not as well developed. But yeah, eventually the vision is that we will have a module that will allow you to pair use and resistance. So you can begin looking and doing some comparisons that I think could be really helpful. So how much carbapenem resistance do you have compared to how much carbapenem use do you have? Are you a facility where there's a lot of empiric carbapenem use, but you don't have a lot of ESBLs? So you could go to your providers and say, look, we're using a ton of treatment oriented towards ESBLs, but we don't have them. What are your use of anti-MRSA agents compared to rates of MRSA? So yeah, it's going to be, I think, a few more years to get that one up to where we are. But I think ultimately, in hopefully 5-6 years time, we'll be at a place where you as a stewardship program will be really able to look at your antibiotic use, compare that to your resistance, and begin to make some of those correlations to try to find opportunities for improvement. Yeah, Robin.
This may be a question that it's better answered in 5 years. What should we think about reporting to the public so they understand that we're doing better with antibiotics?
Yeah.
Because it shouldn't be 0.
Yeah.
And it shouldn't be 100%.
Yeah.
But how do we say we're doing well?
Yeah. I think that's the unanswered question, right? So we're working on that. But what I take some comfort from is that there is at least one precedent for this, and that's C-sections. So there's been a lot of work, and in fact, the other playbook that the National Quality Partnership has done was from C-sections. And so, when I began looking at that work, I said, well, finally, this is one that's applicable here, right? Because we know that sometimes you have to do a C-section, but we also know that there are too many C-sections. And so they were faced with exactly this same problem. Here's the thing, we want to lower it some. We don't know exactly how much, and how much you can lower it differs from place to place. And so, I think they are along this path. I think there are some lessons learned that we can from them, where they have been able to construct and say, look, we think that in this setting for this patient population, a C-section rate of 5% is acceptable. And I think eventually we can get there for antibiotic use. I think we have a ways to go between now and there. But if we can get to that, where we all feel pretty comfortable saying, yeah, for this hospital, with this patient population, for this class of antibiotics, we think this is the right amount of use. And if you're above that, you at least have to demonstrate that you've investigated why you're above that and proved to us that that the use is justified. A lot of work, though, goes between now and here, right? Yeah. But the nice thing is that we have some of the resources to support that work now. Yeah, Joe.
Arjun, thank you very much. Great presentation. One of the questions that I did have in looking through the SAAR information, when it actually lists the antimicrobial agents, it's essentially every antibiotic or every antifungal under the sun, under anybody's formulary.
Right.
Has there been any discussion as to stepwise inclusion of all those, or is it all or nothing, or some of the questions with the vast amount of antimicrobial agents?
Right. So the module captures everything, so it is all-encompassing, but it does break it down. So it breaks it down into some of these different categories, like the ones that I mentioned. And you are able to also customize it. So you can look at individual agents within your hospital. So there is the option to really make it more useful to your use by looking at individual agents, the categories of agents, to try and make it more manageable. Because you're right, just producing a line list of 80 different antibiotics and antifungals, that's not going to be helpful. So we have tried to categorize it. In the next release of NHSN, one of the new display features that we will be releasing is the ability to do like a stacked bar graph within each category. So, if I tell you, here is your use of anti-MRSA agents, but now click a button and I'll show you by a stacked bar graph how much of that use is vancomycin, how much is daptomycin, how much is, linezolid. And so there will be an ability to begin to look and say, yeah, that looks right to us. We think that 95% of our anti-MRSA use, should be vancomycin. Or, whoa, wait a minute, why are we at, why is 30% of our anti-MRSA use daptomycin? That doesn't make sense to me. So it'll allow you to begin to do some of that.
Thanks, Arjun, for coming down, and thanks for touting our legislation. Another thing Missouri does well is a telehealth network, and condition of participation and a state law and joint commission. Those are big words that people listen to. Can you comment on the legislation, the condition of participation, and where you see the role for telemedicine? We've tried to start developing ways to use telehealth to provide stewardship to hospitals that don't have that. Can you talk about some of the specifics and where that might fit in to meet some of these requirements?
Yeah, I think it's going to be really critical, and thank you for pointing that out. I think it's not going to be something I think that would be, you have to do telemedicine. I think the standards are flexible enough that it wouldn't be a requirement. But I think that is a fantastic way for places to get access to expertise that they don't have. So, if you don't have an infectious disease doc or an ID pharmacist in your area, telemedicine is a fantastic way to get access to that type of expertise. I really do think that in a lot of states, especially states, and it's most states, that have a large number of small and rural hospitals, that type of telemedicine is where the future is. It's how we can do this type of antibiotic stewardship where people can get, and it's I think comes in two flavors, right? There's some help that people need at a structural level in terms of setting up a program. So, talking with an expert to say, well, what would a stewardship program look like in my 20-bed hospital? So, talking with someone who really knows stewardship to say, okay, well, let's talk through that. What do you have? Do you have, what's your nursing structure? What do you have in your pharmacy? How can we work through setting up your system for a stewardship program? But then I think it also then comes in kind of the specific instance of, look, we have this urinary tract infection. We're having problems with people over-treating asymptomatic bacteriuria. I've been doing a lot of work with Alaska. And obviously that's a state where this challenge is, I think, on a scale unlike any other state in the country, a huge state geographically with lots and lots of these really small facilities. I was at a meeting in Alaska and a guy stood up and he said, I want people to know that I'm the worst doctor at my hospital at prescribing antibiotics. But the good news is I'm also the best doctor at prescribing antibiotics in my house because he's the only doctor. And so, but what they've done is they've set up an access line. So there's an ID doc, they're paying an ID doc to basically be kind of a consultant. And so, there's a phone line you can call and you can get access to this person. And he's done a really nice job of kind of helping walk them through some of these cases. And they've found it to be very useful. And I think that's the type of model that I think really will be helpful, especially in helping people get started. And what they found is that, once you interact with the ID doc, you begin to understand how to do stewardship. A lot of times, they become self-sustaining, but they said, it was invaluable in getting off the ground, and it's a safety net now. They know that they have access to this resource. So I think that is going to be a huge part of what we need to do moving forward. So be interested in hearing a little bit more about what your experience has been here with doing telehealth for stewardship, because I think we need to get that out to more areas. Other comments or questions? If not, I will be up here and happy to talk one-on-one. And I think, Shirley, we're moving to a break now, right? Okay, so you have a break until 10:30? Until 10:30. Thank you very much.